So, was referred to a little earlier in the day today. Let us look now at the health perspective, at the cost of homelessness, and it is my very great pleasure to invite Professor Paul Flatau to the stage to share his thoughts. Thank you.
Well, thanks very much. So I'll talk about health costs and talk about the economics of it, and talk about the research that we've been doing over a number of years. But I might start by saying there are other costs of homelessness, and their personal costs, costs such as a lower quality of life, we find in our research in terms of quality of life scales, a significant difference between those who are homeless and those in the general population, and a higher degree of... Okay, good. The greater the degree of the severity in terms of homelessness, the greater the gap. And the biggest gap is really in terms of the social relationship side of quality of life, and the question of lack of connection to people and loneliness. And Jim's photo with that family at the end is a very critical type of image, because one of the things that we're finding in our research is that programs such as Housing First programs are doing a good job. We're finishing a study in Sydney, which launching in a couple of weeks, which is a Housing First program with a very high tenancy sustainability rate in the first year, really high. So this is rough sleepers going into housing, staying in housing for a year, 2 years. Extremely high rate. But what I'm concerned about is that whilst the housing has turned out well, I still don't think that we've got the outcomes that we need in other areas, for example, in terms of social relationships and loneliness. So those sorts of indicators and the quality of life outcomes there are not the kind of outcomes I'd like to see. So Jim mentioned that there are things which are necessary conditions. Housing is a necessary condition, but it's not a sufficient condition. And there are other things that you need to do, particularly connect people up to families, but also get people into employment, because employment is a high generator of connection and very important in terms of quality of life. So I'll talk mainly about the economics of this, the finances of this, but I'll bring in those sorts of issues as we go along, and I'll try and talk a little bit about some of the questions that have come up, such as intergenerational homelessness and service integration, because I think they're fairly important. So the basic story that we've been looking at is that there are high costs of homelessness. We focused on health and justice costs. Those mean costs are significantly higher than the cost of service delivery. So reducing those costs through effective service delivery is going to have a significant economic effect. One of the difficulties, of course, with the nature of government is that the benefit that is being derived in the homelessness sector in terms of reducing health costs doesn't flow from the health department into the homelessness department, if you like. And we need to think about that. But effective service delivery can reduce costs. And the study that we're launching in Sydney about a Sydney program, we followed people over a 3-year period with a Housing First type of program. Interestingly, health costs rose a little, and that was primarily because people with health needs were getting their health services. And then they fell in the 3rd year. So some of these reductions in health costs occur later on. But one of the things we also want to focus on is the fact that the costs of homelessness vary, and they're highly differentiated, and there's a very heterogeneous population of homeless people. And this is important in terms of service delivery. We've given up, if you like, talking just about the mean costs, although we will refer to that mean costs of homelessness, and talk more about the distribution of those costs, because I think it's very important. Now, the basic economic proposition, everyone needs to understand this diagram in 1 second, because you're not going to have much more time. But the basic proposition is that on the vertical axis we have, what does it cost to deliver homelessness programs? On the horizontal axis, it's the outcomes that you're trying to achieve from homelessness programs. And there are costs of running homelessness programs. But one of the important things is if homelessness costs money, and if you save that money is an offset to the delivery of those homelessness programs. And indeed, rather than being up here with a positive net cost of homelessness, you could in fact be down here if the cost offsets of homelessness accrue. And if we think about where we would like to be in this diagram, generally speaking, in terms of social programs, most people say, well, it would be great if we were somewhere over here, with a positive net cost, which is not too high, and significant positive outcomes. But in the case of homelessness,
do you want that instead?
no. Well, why not? I like the idea of walking around.
Yeah. You look happy walking
Does it
around.
work?
It's work.
Oh, good. Okay. So instead of necessarily being in that first quadrant, we might be in the fourth quadrant, in the sense that effective homelessness programs may actually save money and produce good outcomes. So that's something to think about. Now, our research isn't necessarily always getting us to that position, but it's certainly something as advocates you want to think about. Let's have a look at a couple of the studies that we've done on health costs. First of all, the Michael Project is a study in Sydney that was completed a year or two ago, and it was the preliminary to our more recent study in Sydney. This is 243 men, and we looked at their health costs over the prior year to their entry into support, although some of them were still rough sleeping at the time. And this is self-report data. Mean costs $20,000 over the year. That's the mean cost. And that is well above the cost of service delivery of a homeless person, as most of you know. So, the possible reduction in health costs is quite significant, and therefore the cost effectiveness of the programs is quite significant. But have a look at the median cost. Everyone knows what a median is. You remember that? Good. So, so that's the 50th percentile, and how much lower is the median cost? It's a lot lower. In other words, health costs in terms of the homeless population, highly differentiated, and it's something really important to understand in terms of service delivery. Same sort of result with a recent study we've done. Mean costs a little lower because the Sydney population that we looked at had a higher level of rough sleeping, and that's something I will refer back to, but in the same sort of domain. So what you're looking at is much higher health costs than the general population and much higher health costs than the costs of service delivery, setting up a very important argument about the cost effectiveness of homelessness programs. But this median and mean question is something we need to look at. When the Michael Project study came out, when the Michael Project study came out, what I found was that people were saying that every homeless person costs this amount, which was the mean cost that we came up with. Well, that's not true. It's certainly not true. The average cost is that, but not every homeless person costs that amount. So let's have a look at that distribution. This is the Michael Project distribution. And again, you have to understand these numbers very, very quickly. Everyone understood it? So what's on the horizontal axis? Costs of homelessness in thousands of dollars. And what's on the vertical axis? Of the sample, that's right. So in fact, 1/3 of that sample were at $1,000 or less. That is low. That is low health costs. And then we get this distribution of health costs rising. So you've got a normal distribution over here, and then this group over here. Cost of homelessness study, a little different, not quite the nice normal distribution on the the right-hand side, but still this big number here. So what does that tell us? It tells us that we have a heterogeneous population, and we need to get behind this question. Why do we get these health costs looking like this? And there's essentially, in my mind, two reasons. One reason is that quite a number of these people are not getting the health services they need in spite of the needs that they have. In the Michael project, for example, we uncovered very high health needs in a couple of areas like feet, podiatry, teeth. They weren't getting those services because of the cost. And the other reason, I think, is that there are a number of people who enter into homelessness with either high degree of resilience or it is a short entry and a quick exit. And if that's the case, then they need support for their immediate crisis, but don't need much more than that. And helping them to move through that immediate crisis and move out is really critical. Whilst the question then is, what's happening in terms of that high cost area? So when we had a look at our Michael project results and also the other cost of homelessness results, what we did was to try and put those people into clusters, and we were using a couple of dimensions, including diagnosed mental health condition and significant drug and alcohol dependence problem, as well as lifetime rough sleeping. And we used those as the dimensions of the clusters, and then had a look at costs against those dimensions. And what we find is that there's a really significant discrepancy between the different clusters. So let's have a look at clusters 1 and 2. Cluster 1 was no diagnosed mental health condition, no drug and alcohol dependent issue, but sometime rough sleeping. Average cost, that's mean cost, 7,193, proportion of the sample 28%. Then we get into clusters 3 and 4, and 3 and 4 diagnosed mental health condition, and you're now getting higher health costs. And then look at cluster number 5 and have a look at time sleeping rough. That's 96 months on average sleeping rough, and many, of course, higher numbers than that. And what happened to their health costs? That's 91,000 over a year, 91,000 over a year for that cluster. And another way of presenting this, which is sort of more visual, is this way. So you can see here, clusters 1, 2, 3, 4, how you've got this high proportion in the very low cost area. And then it starts to diminish, and it diminishes at a fairly even rate. And then you start to see the hills over here in terms of the other clusters, and there is a sort of category 1 climb over here. This is huge. And that cluster 5 is those who are long-term rough sleepers. And that's where the huge costs are in the main. So programs really need to focus on those rough sleepers in the sense of the Misha project, which is the one in Sydney that I'm talking about, was a housing first program for rough sleepers. And the significant reduction in health costs that occurred there. So that group were housed and maintained housing in the main. And unfortunately, there were several deaths in that group. That's a really, that's a really big issue that we really have to focus on. There's the high rate of mortality that's occurring. But that is the big cost area. So the policy implication of this is that we need to look at those programs that can break the cycle of homelessness so they can get the rough sleepers into housing and maintain that housing. But as I said, our research over a number of studies is not showing enough in terms of benefits in 2 main areas. First of all, in terms of employment, there's a lack of movement into employment for those who are receiving support. And by being employed, you can break that cycle of homelessness and poverty. So there needs to be much greater focus by homelessness services in that area. And how do they do that with very little funding? Well, you have to do that through collaboration. And the other thing is that we've got too low a level of social connectedness and too high a level of loneliness and lack of connection of people in effective programs. So that's something that we really need to focus on. So that's the work directly on the costs of homelessness. There was mention about the results from our intergenerational homelessness study earlier, which was an important study done right around Australia with a very large number of people in lots of different services right around Australia. And that intergenerational homelessness study showed, as was mentioned, that around about 50% of current adult homeless people report that one or more of their parents were homeless as well. So a very high rate of intergenerational homelessness, which is much higher in the Indigenous population. It also shows the link between parental drug and alcohol problems, time in jail, mental health problems, and early onset homelessness amongst the group that we were looking at, which is current adult homeless, and a higher lifetime rough sleeping as well. So there is a very direct link between parental issues, parental homelessness, childhood and early teenage homelessness through to homelessness in the adult period. Now, prevention policies then need to focus. So if you've got those who are working with adults with mental health and drug and alcohol problems, need at the same time to focus just as much on the children, because the children are getting higher risk of early onset homelessness and other health problems. So that linkage is really strong. And that is something that we really need to focus on in terms of policy, prevention from adults with those sorts of issues in terms of the children. So, I don't think there's such a thing as, working with an adult who's got a very significant drug and alcohol problems, and what I mean by that is that it affects children in the household. So there is, as a result of those drug and alcohol problems, high level parental conflict and violence in the home. There's no such thing as working with the adults without working with the children. You've got to work with the children because there's such a clear evidence of this pathway that's occurring. So that was one of the important things from that study, to go back in time. And the other study that I thought I'd talk about, which was mentioned here earlier, is a piece of work that we've done on service integration, or collaboration if you want to call it that, collaboration between services. And if you think about a theory of change around this, the idea is pretty simple, that if we have a high level of integration at the policy level between relevant departments who are delivering, in the main, most of the funding into homelessness, and structured integration amongst homelessness services and other services, then you will get a higher level of what we call client integration. And client integration for us meant that the client of those programs themselves would not see barriers and problems moving between services, but they would be going through a seamless type of path through service delivery. And that higher level of client integration would then involve or increase or improve client outcomes. And the study that we did here in Perth, which was of services between Perth, inner city, and out to Armidale, and most services were involved in that study, involved mental health, drug and alcohol services and homelessness specialist services. And what we did was to ask those services about their interaction with other services, but we also asked the clients of those services about their level of, if you like, client integration. And it was a very interesting study. What it showed was that the aggregate level of collaboration between services in that region overall was, in my mind, low. And among the services themselves, desired level of collaboration was higher. So there was a desire to have greater levels of collaboration. But there are these, if you like, micro networks that seem to be existing. And those networks within 2 or 3 agencies are important. But one thing that came out of that study was that particularly when we looked at the drug and alcohol services, who are in, if you like, the drug and alcohol sector, the clients of those services were indistinguishable from the clients of the homelessness services. And that is a really important thing, because that means that whilst we have this, if you like, homelessness sector, specialist homelessness sector, and we have this thing called a specialist drug and alcohol sector and a specialist mental health sector, the problem with that is that the drug and alcohol services are in fact dealing with clients who are indistinguishable. So then the question is, why are, these two sectors actually need to be completely integrated, if you like. And I remember a story from a couple of years ago where we were going to put on a conference for specialist homelessness services, and I said, hang on, if it's about homelessness, why is it for specialist homelessness services? Sounds a silly question, but in the end, it's an important question, because the drug and alcohol services were exactly the same in terms of the clients, pretty much. Mental health, a little different. There's a little bit more differentiation there. Now, what did the clients of services say? And these are some of the comments. I think the lack of communication between the services working for me is currently a major issue, and I'd like to see this changed in pretty dramatic statement, that one. All services should have information on each other and be aware of what's in their neighbourhood. So these are fairly directed comments. In terms of some of the stats, here's a good one. This is by clients. What's the importance that you place on care coordination between different services? And the light colour is the very important area, and then you go quite important and so on. So you can see that close to 50% of clients were placing a critical level of importance on care coordination between different types of services. So that means that this is a really significant issue from the client's point of view. They are seeing barriers, and they themselves are saying we should have greater care coordination. The services actually also said we should have greater coordination between our services. So this is something that we need to look at, because coordination and integration is costly, and you need to be able to put money and resources into this process. So I might end it at that point, other than to say, because I forgot the last slide, other than to say that there was a relationship between those services that had higher levels of service integration and high levels of client integration. So there is some rationale for higher service integration, because it does flow through to clients who then see that their services are working well together. So, thank you.